Good evening, everyone.
Good evening.
Set.
Good
Good
evening.
evening, good evening.
Good evening. So,
Good
I have
evening.
good evening. I am Kanchan Saini from Dr. Lalpat Labs. So, I'll be doing the bios for all the guest speakers today. So, Dr. Som Shekhar will be a little bit late. He's on the way. So, once he'll join, then he'll upload his presentation. So, since the audience are joining, so we are in live session right now. So, a very warm welcome to all the guest speakers and attendees. Thank you for joining the today's webinar session on prognostication in early breast cancer. How we can position various prognostic tests in the Indian scenario. It's really an honor for me to introduce our guest speakers today. In today's session, we have Dr. Somshekhar SP as a speaker. He's the chairman and HOD Surgical Gynae Onco and Robotic Surgeon, Manipal Comprehensive Cancer Center, Bangalore. He'll be joining in a while. Then our next guest is Dr. G.S. Bhattacharya, who will be moderating the session. Dr. Bhattacharya is practicing at the Salt Lake Medical Center, Calcutta. The doctors who will be joining as panelists are Dr. Arvind Krishnamurthy. He's the professor and in charge of Department of Surgical Oncology, Cancer Institute, Adyar, Chennai. Dr. Harit Chaturvedi. He leads the oncology team at Max Healthcare, which consists of 80 oncologists. Then Dr. Hemant Malhotra. He's a professor and head Department of Medical Oncology at the Shriram Cancer of the Mahatma Gandhi College Hospital, Jaipur. Then we have the fourth panelist, Dr. Govind Babu. He's heading the medical oncology in the HCG Cancer Center, Kormangala. And our fifth panelist is Dr. Manjari Bakre. She's a founder and CEO of OncoStem Company, with whom we are organizing the today's webinar. Then Dr. Rajiv Tangri. So Dr. Rajiv Tangri is a national head of histopathology and cytopathology department at Dr. Lalpat Labs. So very soon we'll be starting the today's session. So everyone has to wait for another 5 or 10 minutes because Dr. Som Shekhar is on the way. And once he'll join the session, then I'll upload his presentation and we can then start the session. Hi, Dr. Heyman. Good evening.
Hi, everyone. Good evening.
So, Dr. Hemant, you have joined as a delegate. So, once the panel discussion will be on, then I'll put you as a speaker. Good evening, everyone.
Good evening.
So we are waiting for 5 minutes. Very soon, Dr. Somshekhar will join, and then we'll start the session. Am I audible to everyone?
Maybe we should start the panel.
Um,
Hello?
yeah.
Hello?
Hello.
Yeah, maybe we should start the panel instead of waiting for Dr. Somshekhar.
Okay. Should I upload the presentation?
I mean, if you want me to share it from my slides, I'll do that.
Yeah,
Or
Yeah.
if you want
Uh,
me to, you want to do it for me, that's fine.
okay. I'll just upload the presentation. Then you can handle the slide.
Yeah, if you can do that, that'll be great. If you can upload it, because
Yes, I'll just do that.
no, yes, I think we should start because we already waited five
yeah,
minutes.
I don't know where Shoma is caught.
Yeah, yeah.
Uh, I think it's a bit. Yeah, we have waited for 5 minutes.
Yes, can you hear me? Hi, Govind.
Yes, yes,
Can
Hemant.
anybody just find out where Dr. Somshekhar is?
It's okay. I
I
think
just
we'll start.
Yeah, I just called him. He said he has some emergency, and he's in the car right now, so he got late.
So I think we will start the panel, then we
Yeah,
can
so
listen to
I'm
his
just
talk.
uploading the presentation, and then we
Yeah,
can.
yeah. Sure, sure. Yeah.
Govind, I can see you now.
Good.
Can you see me?
No, I can't. You have
You
to on the
you have
video.
to adjust your
Put the
video
Video
on.
video.
on.
Where is the
It's a
video? But I
very
don't know there. So
so
many.
it's a very
Huh?
On the top of the panel, there are
on the top of the
black
panel.
dots.
Yes, very first button you have
There
to
is a
click.
top of the panel. There are four
When it turns
boxes.
blue, that means you
There
are on. Ah, now
Can
we
you
can
see
see you.
now?
four
Yeah.
rounds. The first round
Yes,
on your
yes,
left
yes.
is the video
Can you
camera.
see now?
There, we can
Yeah,
see
we
your
can see
face.
you. Fair and
Okay,
clear.
good. Can you see my
Good,
cup
good.
of tea also, guys?
Yeah, we can see you. You're looking handsome.
As always.
Yeah, we can.
I turned the video off because then the bandwidth decreases, then the audio is better.
So why are you worried about
Yeah,
bandwidth, Govind?
absolutely.
Because you can't hear the way sometimes.
We can
Audio
hear you.
doesn't
We
get.
would like to hear you and see you also, man. Smart guy like you, you know.
Arre, thank you, thank you. So how's Jaipur?
We've had some rain, horrible rain today, man. Everything was flooded.
Oh,
I'll send you some
Did you buy
videos.
a boat? Did you buy a boat?
Almost decided to.
Because I know something. The Jaipur boat is rocking. It's been rocked and it's rocking.
I know.
Yeah, so
Okay.
we'll have the panel
Okay.
discussion slide right here.
Yes. Yes, GS, I think we can start.
Uh, Hi everyone. It's out of turn, so I'm going to play hit jockey to start with. I think the panelists know each other. We have Arvind, we have Harit, both are surgeons. We have Babu and Dr. Govind Babu and Dr. Hemant Malhotra, who are medical oncologists. We have Manjari Bakre, who actually is someone who specializes with artificial intelligence and machine learning, and is someone who does a lot of work with prognostication of breast cancer these days. So, when I start off this thing, I'm going to tell you that we will be discussing what we have been told. I just want you to look at that book. There's a published book, Artificial Intelligence Technique in Breast Cancer Diagnosis and Prognosis. And it's not the first book, there are 11 books on this series. So I would suggest, all of us after this meeting try and get it on the net and read it if you can. That's my disclosure, which I need to, and my conflicts of interest. And to tell you that I actually, for this talk, have no conflicts of interest to do anything of that. I have a conflict of interest, but for this talk, I don't need to put it across. So, Babu, I think you're going to be happy. 20 years back, this was the NCI's dicta. Adjuvant therapy of breast cancer means anything more than 1 centimeter in size, the T size of the breast tumor. All that you had to do was give chemotherapy. The bar was pretty low. Now, I really want to tell you all something is that okay, those animations are not there in this mix up. Soma has joined the room, I think so. Soma can also get onto the panel. So let me ask something that we have now three surgeons there. So when you get an early breast cancer, right, what comes into your mind that after your surgery, what would you like to know? From your medical oncology colleagues from the lab, what would you like to know and why do you want to know? Can I start with you, Harit?
So Dr. Harith has just signed out. He'll be right back.
Okay, fine. Then I can, Dr. Arvind, please. Dr. Arvind?
They all have emergencies.
Yeah, I do agree with you. Soma, are you on?
Yes, sir. Can you hear me?
I can hear
Yes,
you
yes.
loud and clear. Don't worry.
Hi,
Okay.
sir.
So, Soma, to start with, let me ask you that when you, as a surgeon, do a breast cancer surgery,
Yes, sir.
what information do you want after that would make a difference?
Yes, sir. Sir, even not just before putting the knife, not just after putting the knife, before that. Now we know that stage is a relative thing. Gone are the old days when we used to be worried about stage 1, 2, and 3. Sometime a better genomic profile of stage 3 is better than stage 1. So I would not operate a patient unless I know the histological proof when we do a triple assessment and do a core biopsy. Mandatory estrogen receptor, progesterone receptor, HER2 key 67. So
So,
then I would
no,
look
Soma,
at
you
all
have
that.
operated the patient.
Yes, sir. So
You
once
have
I have
operated the
completed,
patient.
once I have completed the surgery, if we have not completed the full immunohistochemistry panel, I will complete that. I would look at the T size of the lesion, final pathologically, and the pathological lymph node status, and that
So
primary margin status. So I would look
so
at
the
this point. Then go ahead.
so the gatekeeper of the departments of any breast cancer surgery, the gatekeepers as I call them, they all say that biology is more important than the stage, or as important or as the physical stage of the patient. And you need to know that, which we are going to be looking at the multi-gene assays basically for treatment sparing, treatment selection, treatment directions, and treatment confirmations. I'm going to ask my medical oncology colleagues, both of them, do you all agree to this?
100%.
So let's put it this way. We had this, and I just want to put it across. I guess we don't have the animations coming up. Let me ask you all something that when you do a test, do you really ask for the efficacy, the effectiveness, and the efficiency of the test? Babu, can I have you on this, please?
Yeah, I think when we ask for a test, it goes without saying that these are understood and included. Otherwise, I won't be asking these tests. if I'm not sure of all these three parameters.
Okay, fine. Perfect. So we'll keep that in mind, that you got to know how effective the test
Yes.
is, how efficacious the test is, and how efficient the test is. That's going to be very, very
Correct.
important, right? I think,
Yeah.
Soma, you would agree with the statement that these three are very important.
Absolutely, sir.
So there is a dilemma when
Yes,
we
can
talk
I
about.
make a comment? Yes.
Please do.
Can I come in and make a comment? And I think
Yes, please.
in addition to these three
We'll
things
come to
which
that,
you
Hemant.
mentioned, which are
We'll
very,
come
very
to that.
important.
We will come to that. We will.
Yeah.
I know what you're coming to, but we will definitely come to that.
Okay.
Okay. Now, there is a dilemma, as I said, and specifically when we are talking of a hormone positive breast cancer. That's the biggest chunk of breast cancers. I think everybody would agree with me. That's the biggest chunk. And these, we need to know that who is a good prognostic and needs only a hormone, and who is someone who needs a chemotherapy. Unfortunately, this dilemma gets worse because the prognostic dealing that we do, it tends to make things cloudy and worse. And when I move into this particular section, I'm going to really get into it and say, what is the commonest test that you all like to do beside the ERPR, HER2, and Ki67 in a early breast cancer? Yes, Hemant.
So I think the first thing is that you look at clinical markers, and we've been aware of these clinical markers for some 2 or 3 decades, if not more. You would consider the patient herself, like the age of the patient, whether premenopausal or postmenopausal, the age of the patient, the comorbidities which the patient has, and of course you could do a economic, socio-economic assessment of the patient. And then before you go on to the molecular tests or the pathological tests, you would go to the simple pathological clinical markers like the size of the tumor, the grade of the tumor, whether lymph nodes are positive or not, and the number of lymph nodes which are positive. Is there any lymphovascular invasion present? So all these factors, the background of the patient, the comorbidities, the tumor characteristics are extremely important, and we've been basing our clinical decision making regarding adjuvant treatment on these things for several decades. And then, of course, as you mentioned, the hormone receptor status, the HER2 receptor status, and possibly the Ki67 also.
Perfect, Hemant. That's a comprehensive answer. I think Harit has joined back. Harit?
Yeah. Yes.
Harit, you agree that post-operative, you have done a lumpectomy in a patient. We all have a dilemma for further treatment, but before we get into the decision of the dilemma, we all like to know certain characters, the tumor character, the patient's character, and we like to actually get into a sort of a algorithm synthesis to make a decision. Do my surgeon colleagues Harit and Soma agree that?
Absolutely.
GS, I need to know the surgeon's character also.
Most important independent
That is
prognostic
Govind
marker.
Babu, ready for the evening. Yeah.
Okay,
Yeah.
okay.
Certainly, certainly.
So can we? Hmm? Okay, so if all of us agree on that particular. Let's move along. I am sure everybody is looking at the screen. This is the gene array, which is actually used
Yes.
commonest. Soma, would you like to take a shot at this quickly?
Yeah, definitely. See, next to estrogen progesterone receptor, then the HER2/neu, we give a lot of importance to the proliferative index. I know that all these are there, but all of them are not validated in real time with clinical applicability. So, estrogen progesterone receptors, and we give a lot of importance to Ki67. Now we know luminal A, B also has this. Out of all these things in real time without a genomic assay, uh, these are the main thing. But the proliferative index, especially cyclin 1b and BBL2 and Ki67 and cathepsin L2, are most frequent component of most of the genomic assay to prognostify and also to change the management.
Uh, Anybody, Harit, you want to add something to this? What is there?
So basically, it's about the aggressiveness of the tumor, as he has highlighted. So few things are validated, most of them are not validated.
So, Babu and Hemant, you will accept what is being said because this is the oncotype DX's genes that we
Correct.
look at.
So these other things which Dr. Hari told are not validated. That is right, but validated only in this oncotype DX, not
Yeah.
elsewhere.
Okay. So now let me tell you something. Even I'll tell you. This is supposed to be for ER/PR positive breast cancers, right? Or
Correct.
hormone positive, HER2 negative. But watch this entire slide set carefully, and you will find out that there is an area in which we have written HER2 and underline that. Okay.
Correct.
So here we have a ER/PR set, and we are looking at the genomic levels of HER2 to tell us whether this ER is right or this ER is poor risk. It's kind of an antithesis that we actually have got ourselves into. And if you look at it carefully, all the markers are markers for proliferation. There is still more important thing which was there on this slide. As I said, the animations have gone. This slide says that there is something that, if you look carefully, is a mathematical equation. And in that mathematical equation, the most important equations are the proliferative index and the HER2, the two strong drivers of the entire oncotype DX. So, the entire test using genes that are not validated in and outside this phenomena and getting into this is something that we all would know is not right. So here are three case scenarios, and I would like to have quick things to this. 1.4 centimeters, ERPR positive, HER2 negative, node negative in general. Would you order a genomic test if she was 40 years old? Harit, Soma, because they would go to you before they came to the medical oncologist.
Yeah, I'll be tempted to offer. Yes.
Yeah, there are two ways of looking at this. Sir, by rule book, if you look, most of the genomic assay by rule book are usually in postmenopausal or perimenopausal. But in reality, in practicality, in this patient with T1B, N0, M0, and I know key citizen, I would definitely order in the option 1.
Okay. Babu, Hemant, you all agree to this?
Yeah, in the younger patient, yes, but like Som said, all these other panels are mostly perimenopausal and postmenopausal. That is one thing we need to keep in mind.
So less than
So I
40,
think that you will bring towards
asking for
the
the
discussion
above
that
40, yes.
the validity of these assays do not reflect the patients that we see in our context.
We'll
I
come
think
to
you'll
that.
bring that up, right? Yes.
Yeah, I agree with you. We'll definitely go into that. But right now,
Hello.
40 years old,
Yeah, exactly.
you would do it.
Okay.
Okay, fine.
Yes.
Has Dr. Arvind joined in? I don't think so.
Yes.
Hemant?
Yeah.
Hemant? Okay, he's not there. Yes,
Sir,
go ahead.
what I just want to say, it is something very important to analyze. Each trials which are there, MindAct trial you take or any trial for any of them, it's very important to understand the strength, weakness, inclusion, exclusion criteria. Now, not most of the genomic assays have been validated, tested, or proved to be effective in node positive. It's very important. PAM and then ProSigna has about
Soma, let me cut you off. Let me cut you off because we are not discussing.
Because the last scenario is node positive here, option 3.
I'm talking with that one.
Not able to hear, voice is breaking.
We can't hear you.
Yeah, we can't hear you, sir. I think some network problem on that.
Can you hear me, Soma?
Very
Sir, it's breaking up, sir.
Hello, Soma, Harith, can you hear me?
Yes, sir. Now we can hear you.
Now we can hear you. Yeah.
Again lost.
Okay. Let me ask you once again. If this, hello,
Yeah, go
60,
on.
would you do the test?
Sir, sorry,
You're lost again.
I said if this patient, can you hear me?
sir,
Yeah.
Can you hear me?
patchy networks, yeah.
I said at the age of 60, would you do the test?
Yes.
Fine. Okay, Harit, agree with you. If this was 80, would you do the test?
No.
Only hormone.
No.
So Harit says,
Yeah.
no. Soma, would you do it at the age of 80?
Sir, I would not put age alone into criteria because I would look at the
No,
life expectancy.
Soma, just
Yes.
stick to this. 1.4 centimeters ERPR positive, no comorbidities to disturb the patient. You do the thing or you don't do it.
Sir, option 1, 80-year, no.
No. Fine. Babu, any idea why I wouldn't do it in 80 years?
Yeah, because you're clear you're going to give her hormone therapy. That is why.
Fine. And there is no data of the age of 75,
Yes.
even if I look at
yes.
Killer
in
X.
any of the
Above
studies,
72 years.
Yes,
Yeah.
above 75, nothing that we can look at. Okay.
Correct.
So the next scenario is 60 years old patient, ER positive, HER2 negative, node negative, IDC. Would you like to order a genomic test if the tumor was 2.2 centimeters?
Yes.
So
I
Harit,
would order, sir, yes.
And
Harit says yes, the surgeon says yes.
yes.
Babu, yes. Hemant,
Yeah.
okay, fine. 3.2
2.2,
centimeters.
yes.
3.2 centimeters. Would you order the test?
Yeah, I would order the test.
3.2, I would not ask.
Soma,
Sir, I would definitely order.
at 3.2.
Yes, sir. Even though I know the data is there, real scenario, I order it.
Harit,
Yes, I will order. Yeah, 3.2 is fine.
if I go ahead and say at 3.2, where is the data?
So
There is
I
no
do-
data for that.
So if there is no
Yeah,
data,
there is no data, so I will not ask.
so so that's a very pragmatic method of looking at it, because when I know the cutoff values according to that particular entire trial on which you are basing it was this, how do I make a conclusion that it is not supposed to be what was not
Yeah.
there? So this is a situation I think doing the genomic test may not be wise. And now,
So
Harit, what is
my
the
only
average
counter
size?
to that- Hello, yeah. GS, my
What's the-
only argument to that is that if you look at the tumor biology, if this is all favorable node negative, everything is there, and the patient is 60 years old, what is the benefit of adding? Suppose you won't order, but will you go for chemotherapy?
I will look at the other factors before I make my decision.
So there is
Exactly.
I just said
it
whether
is
we do
heavily
genomic
loaded
test.
towards consideration of only hormone therapy. The data will be very sketchy on supporting any adjuvant chemotherapy in this case. And
No.
therefore, to just support that decision making, it may be helpful to have a genomic study done.
No,
No, but-
Harit, for a tumor of this size, you have no data.
So
So I don't think you
3.2,
can.
I know, but
Yeah, so
please.
you can't say there is evidence. So there's
And
no
now I'm
point in
going
doing the test.
to let me ask Harit and Soma specifically now.
Yeah.
Well, as a surgeon, you operate. What is the average size of tumors that you have
Today it is about 2.5 centimeters.
in your general practice?
Yes.
Sir, I will give you exact data. We published a paper across India as of today, 3.2 centimeter across India. In my center, 1.8 centimeter.
So, so you look at it. The average Indian data is 3.2. You and Harit would be outliers.
Yeah.
Because
Okay.
we practice the
So
center
there's a
where
big
we
chunk of
practice
a
is
patient with
different
T1
type of
disease.
So,
Dr.
Dr. Tangri, have you joined? Would you like to add something? Dr. Rajiv?
Yeah, I'm on the call.
Yeah.
Yes,
so-
Rajiv, tell me. Hello. With the average size of the Indian tumor being more than 3 centimeters, can this be said that we want Oncotype DX on the Prime Minister Yojana scheme? Yes or no?
So with 3 centimeter average size, no.
So we get it. 3.2, you don't.
Yeah,
Let's come to the
T1
next one. 1.4 centimeters. 1.4 centimeters. ERPR positive, HER2 negative, one node sentinel positive, right? Would you do a genomic assay if the patient was 40 years old and premenopausal? Harit,
In 40, I may not, but 60, I would.
one node positive. Please keep that in mind. There's
Yeah,
one
yeah,
node positive.
yes.
Soma,
It's very important to understand no genomic assay is strongly validated in node positive. However, if it is 60
Yes.
and one sentinel lymph node, I tend to ask and I would then probably incline more towards Prosigna or a can assist.
so at 40, you would say we would not do
Yes.
if it was a node positive. Given on today's date, till the Pondrex data comes in, right? We would
Yes.
say that we won't do it. Okay.
Correct.
All right. 60 years old, you would do it. 80 years old,
I will do it. 80 years, I'll put on hormone therapy.
60 years old, 4 nodes positive. 60 years old, 4 node positive.
No, only chemo.
I will not do.
Yeah, no.
I will not do.
No, that is stretching the genomic assay too much.
Yeah.
Rajiv,
And it will break.
Rajiv,
No, sir. With 4 nodes positive, will not do.
perfect. So let's move on. 60 years old, grade 1 tumor, 0.8 centimeters, ER positive, 90%, HER2 negative, node negative. Would you order a genomic tumor assay? Harit, Soma.
Sir, most of the data is 10 millimeter, that is 1 centimeter and above. 0.8 is something with this particular, probably I would go ahead with hormone therapy straight away. It is T1A tumor. And
Yes,
key
and
sensitivity
grade
is
1.
missing because the data is 10 millimeter and above.
Harit,
T1B, yeah. So I would rather 0.8 centimeter ERPR. Okay. So benefit is very marginal. I think we can go only by hormone therapy. Yeah.
perfect. Do my medical oncology colleagues agree to this?
Yes, yes. Especially it's grade 1,
Grade
here
1,
90%.
grade 1.
Yeah.
Okay, perfect. 60 years old, grade 3, 0.8 centimeters, ER 20% positive. Would you do a genomic test? Harit,
No, go for chemo.
Soma,
Very weak ER, triple. It will more like triple negative. Yeah.
Babu,
Yeah, that's right. I will
Hemant.
not ask.
Hemant.
Hemant is missing.
Okay, that's fine. Rajiv, we still don't have Arvind in the group anyway. So let's have a look at it. If you have a lobular carcinoma or a tubular carcinoma, do you do a gene array in the form of 21 gene array?
Sir, two things. Number one, lobular carcinoma data is very, very minimal. If you see the recommendation, most of it is to ductal cell carcinoma. I would be little uncomfortable to use in exclusive lobular, but not in alone. I would look at other point. Tubular carcinoma, I don't mind because tubular carcinomas, as per Hertog's trial, are much better than ductal cell carcinoma. Tubular carcinoma, I would, but lobular, I would be little skeptical because there is no data.
So in tubular, you would do it or you wouldn't do it?
Tubular, even though data is not there, I know it would behave better than IDC. Looking
I
at
think-
all other parameters, age, I would not shy away doing in selected cases.
I think something like 11% patients were tubular even in Telrex. So there's a good chunk of patients who are very favorable, and I think that's a good validation. We should do the test.
Harit, but when they looked at the subsector analysis, which they had it was not a pre-planned analysis. The data said basically that in tubular there's no benefit in doing that. You just, in fact, it all behaves as low grade. All the 11% were very low grade tumors.
Yeah, but they were okay.
So actually, both in tubular, in plain lobular specifically, you wouldn't like to do that test. Fine, perfect. Let's move on. I'm going to ask you to focus on the second point. You have a 3 centimeter DCIS. Do you do a 21 gene assay? Yes or no?
So there is an assay available for adjuvant RT. We have used only in one case, but it's not widely practiced. We have not for adjuvant therapy, only for radiation.
But that's also an adjuvant therapy, isn't it? It's not adjuvant chemo. Soma?
Not routinely, sir.
Yeah.
No.
Hemant?
No, I don't think it should be done. Can you hear me?
I can hear you. You're loud and clear.
Okay, so
Yeah,
I
yeah.
haven't been able to contribute for the last few minutes
We'll make
because
you
I don't know
contribute.
there
I'll
was
make you go.
there was
I'll
some
make you.
problem with my audio, and I think one important thing which should be highlighted right at the beginning of this discussion is that for a patient who can't economically afford a 60,000 or a lakh 50,000 test, you have to make your decisions on clinical factors and not think of the genomic test. So that has to be kept in mind that you'd rather use the money and spend it on hormone therapy, the tamoxifen or an aromatase inhibitor or chemotherapy than have him get bankrupt in getting the test done. So that is something which needs to be kept in mind right at the
Perfect.
first.
So, sir, there is a query on the chat
We
board
will.
from Dr.
Yeah, we will.
Manjula Rao. Dr.
Yes,
Manjula
please.
Rao.
This is a query. Can anybody read it?
So,
Can
Dr.
anybody read it?
Yeah, I'm just reading it. Dr. Manjula Rao, breast surgeon from Cancer Institute, Adyar here. I have a scenario, premenopausal lady in her early 40s, ILC, luminal 8 disease, but tumor size 5 centimeters. Is there a role for chemo in this case, or do we do a genomic assay here?
5 centimeter disease, I think she should receive chemo and she should not receive the genomic test according to me.
Yeah, I second that.
Absolutely, yeah.
And node negative on axillary clearance. Sorry, missed mentioning that. The
But
same.
No, still 5
5
centimeters
centimeter
is,
disease,
yeah,
there is an absolute indication for adjuvant chemo. No, do not
exactly.
waste money on the test.
Even if it is free, don't do it.
Okay, GS, come on, wake up, go ahead. What happened? We can't hear him.
So he has just joined the room again. Maybe some audio problem.
Did he go out of the room?
So he has joined back.
So what platform are we using? Like I'm having a
Hello,
lot
can
of
you hear
trouble
me?
with this platform.
So this is a webinar jam platform.
Yeah, it is not very clear at all, unlike the other platforms.
Little bit not user friendly. This is.
Yeah, that's right. And you know, it keeps going on and off, keeps kicking you out of the room.
Doesn't look like it's validated well.
And difficult to see all
can't.
other
Can you hear me?
attendees.
Yes,
Yeah,
are you
yeah,
there?
correct.
So our panelists-
Hello.
Yeah, we can hear you.
Go ahead.
Can you hear me?
Yes, go
Can I have my
ahead.
slide back?
You've left the room.
It says, but sir, you
You
left the room. And there's a prompt saying room expiration in 3 minutes 20 seconds.
No, it will not
No,
expire.
sorry, 3 hours. Okay.
Expiration or explosion going? What is it? Is there going to be an explosion in the room?
Explosion for them. I know.
3 minutes 20 seconds.
So where is our moderator? Where has he disappeared?
To ignite the fuse.
I think his network is little bit shaky today.
Correct.
No, I think this is the software issues. Like I could hear all of you guys, but I couldn't see myself or make myself heard for several minutes.
Okay, I'm back. Hello.
Yes, sir. Welcome.
I'm
Welcome back.
Anyway.
GS, I think we need to use a different platform. This is bad.
I don't know what's wrong. Can I go back, please, to the slide which we stopped?
Yeah. So which slide do you want me?
This
So you
platform
can use
doesn't
the
seem to work
preview
well.
button and you can just flip the slides.
I think it's a wrong choice of a platform.
Okay, so this is another case that we have a quick look at it. Okay. 67 years old woman, lumpectomy and axillary dissection for a multifocal HER2 negative 0.8 centimeter IDC. Okay, with IDC. She received 6 cycles of chemotherapy followed by 5 years of anastrozole. No side effect, bone density normal. Not positive. What would you do? Would you do a genomic assay on this patient to try and tell you whether we give it for 5 years or 10 years? Hemant?
No, I would not.
No.
Hemant Babu?
I would not, because it is a multifocal thing.
Thank
So
you.
I would have an extended hormone therapy for her.
Perfect. So even if it was not positive, we would do the same thing.
Yes.
Now let's have a look at it. I will not go into details, but tell you these four assays basically have, which are looking at so-called prognosis. The so-called, we would all realize something very clearly is that these assays are actually within their own, they have a very poor concordance. The concordance lacks very much, whether you're doing a mammo print or you're doing even a PAM 60 or you're doing a anything of that sort.
Absolutely.
You
At best,
actually
at best, they're only 85% concordance.
Correct.
At best.
Correct.
That is the main worry when you ask for a test.
perfect.
Where will you end up?
So we don't have a very good thing out there. Whenever we ever order for Oncotype DX, the median age was 55. There was no patient above the age of 75. The median tumor size was 1.5, and the worst grade was grade 2. That was the commonest grade, 57% of patients. Please keep this in mind and remember that this is how we're supposed to look at it. I also want you all to look at something in this group of 11 to 25 intermediate risk, which Taylor X actually decided upon. Please look carefully, and I've circled it. They used a hazard ratio of 1.32 in non-inferiority margin, saying that you could afford a 30% risk by not giving chemotherapy. And I don't think that
we
is
know the
acceptable.
Avalov rule of 10%.
Well, it has
never
been
take more than
accepted.
10% risk. And here they have 30% risk.
Yeah. So they just seem to be playing around with statistics and.
Hello. Yes.
I will not agree on this. Yeah.
Yeah. Agree with you, Babu. So let's keep moving fast. Okay. Again, in the situation of premenopause or younger patients, right? And we would see that the benefit of chemotherapy still persists and will persist. The worst thing that they ever did, and I'm going to call it the shifting of the goalpost. Babu, do you want to say something about that?
Yeah. Yeah, I think, when they initially started, they had a different cutoff for the intermediate, low risk and high risk. But when they started analyzing, they quietly shifted it. So this is like, you see the ball coming and then you shift the goalpost so that you score a goal or don't score a goal. So I don't think this is the right way of doing, but they don't have any explanation. When I asked the people who shifted this, we had a meeting. They had no perfect explanation. They just said, no, we wanted to decrease the risk of people who would not get the benefit of chemotherapy. But I was not convinced about their answer.
So, and let me put it in my view. There was an attempt to overfit, which is proven and statistically there. The bioinformatic validation of the genes which Soma bought out, you bought out, Hemant bought out is not there, which is true. And there is no prognostic factor there. I also will tell you that the ICMR guidelines of India says that we don't need to do these genomic analysis because they're not validated in Indian patients. Of course, in the same data, they also have made a statement that you can use IHC4. And I again raise a question asking, where is the data for IHC4 for Indian patients? So till that time, we will see what's happening because I'm going to leave it. So I'm just going to sum up by saying that
just one comment
this
I
is
would
the
like
use
to make.
of certain.
Just one comment is
Yeah,
about
go ahead.
the KI67. That itself is a difficult assay. There are not many good labs that can actually have standardized and have validated their KI67. In fact, the last CEO of ASCO says he never believes in KI67 even in the US. So how do we take that here?
Exactly. And I agree with you. When they analyze the lab, less than 10, they're accurate. Above 30, they're accurate. 10 to 30, hardly concordance of 45%, which is the area of interest for us.
Correct.
Absolutely, Soma. And I have a statement to that. If you're from Mick Dowsett's lab and the test is done in Mick Dowsett's lab, KI67 is a dependable test. Anyway, that's how when we do a test, this test has to be validated. a technical feasibility, analytical validity, clinical validity, and clinical utility. And that is a built up pyramid. Unfortunately, in reality, this is what happened with Oncotype DX. And this also happened with MammaPrint. This also happened with Prosigna. So keeping that in mind, we really have to ask ourselves, can we replace this with something? I would just put down out here and say, the science of omics is not one gene. We are not in the era of doing one gene test. We are not in the era of actually trying to go ahead and just look at a microarray. Patient has to be seen, patient data has to be seen, which Hemant said. We need to look at the full genomic character of the tumors if possible. Also look at basically, if we can, into the tumor character. And there is something called computational biology, a computational model that becomes very important. This cannot be done with methods of validation. I'm not going to go in it, but I'm going to just show you certain things that should carefully that one of the biggest requirements for anybody who is practicing oncology with breast cancer is to try and pick up patients as early as possible. Something is wrong here. So I'm going to keep it out here and just show you something. That's a paper, published paper of machine learning in breast cancer and how you handle that. You look at patient-related, tumor-related, and biochemical factors to be taken into account when you draw that up. Unfortunately, none of our touted methods look into this clearly. But there is data telling us clearly that machine learning actually improves everything there. And there are trade-offs. Okay? These trade-offs have come up, and we have to keep that in mind. So I'm just going to jump across that and come into something and tell you all. I'll skip the slides and come into the slide which has all the features. Okay.
So, Dr. Somshekhar, would you like to present?
I don't know whether I can see it.
Would you like to present your slides also, which was missed?
Yeah. Once Bhatta sir finishes.
Okay.
Yeah. So, when we are looking at these practice guidelines and we're looking at this carefully, Hemant brought up an issue, quality and cost. I'm really going to ask what percentage of your patients, right, can afford this test of Oncotype DX?
Who are you asking, GS?
Affording is one, getting it done is the next. I had a patient who fitted in for getting this genomic analysis done. They were, they were well off to get it done. But when I discussed with them the pros and cons, the cost of treatment, cost of the assay, they said, we will take the treatment. We don't want to waste money on the assay. So even if they can afford, whether they want to do it or not is the next question.
Yeah, and sometimes when you counsel them, you also have to very clearly tell them that the result might be in the intermediate category and we are back to square one after spending 2.5 lakhs of rupees. So that also has to be counseled to them.
Of course.
GSB sir, I'll give a straight answer. I practice in a corporate hospital, high clientele. Still, less than 30% of patients agreed to do this with their own pocket.
Haris, what about you?
So same, I think the numbers, people who are agreeable and all, basic thing is, am I convinced that this is a test which will add value in this case? If that is there, then the whole conversation is according to that. So for each one of us, that rule applies. As far as the segment which can afford, I think about 20-25% people can afford it, but
okay,
all depending on this.
Hello, you're there? Rajiv, are you there?
No, we can.
Okay, Rajiv is not. Let's move along.
Yeah.
And let me tell you that when we.
Yeah, actually, the thing is that we can only accommodate 6
Okay, that's fine.
in the panel. Yeah.
That's fine. Okay, let's move on. Okay, so the tumor marker recommendations we have. I'm just going to tell you all something. Try and look at the first graph, first part of the tumor, first half. That is evidence-based medicine, right? And that medicine tells you there are gaps. We fill in that gap with our experiences. What we are talking right now is our answers in doing it. And that continuum becomes actually a consensus guideline. So the problem is that if we are not going to look at first at the evidence that is available, we actually will not do it. And to look at the evidence properly, we need to actually grade it. I would like everyone to go back later and look into this carefully. I just put down how do you validate a test properly, and I'm sure Soma is going to talk about this. Okay, so the quality appraisal of gene analysis and including oncotype DX or even mamma print leaves a lot to be lot, specifically in the classify derivations and validation, which is rightly pointed out that you have a set of genes which we have not, we don't know what to do. Anyway, so as I would say that these genes, we have a conclusion there. At the present, it's required. We need something that will be better, and that's exactly I'm going to ask Soma to continue on. But do we not want to consider cost? And I think so Hemant started that by saying we need to look at the cost if we really want to do it. So let's have a look at the cost. So when they compared Oncotype DX and Mamma Print and tried to look at what budgets was saying in USA and in Canada, what they realized is that majority people in real world would not do it. And Soma's statement of 30% in his corporate practice do it. Let me tell you, 45% in US who deserve it don't get the test done. So that tells you in the real world impact has been not good. And the other part of it has been that if I look at the decision making trees that are there, the decision making tree tells me very clearly that the value of this is something not done. So in the last couple of slides, I'll just tell you all that you will find out that 26% of high grade oncotype DX, in spite of being there, did not receive chemotherapy. Right? 8% of those with low risk oncotype DX still receive chemotherapy. And the quality of life and the dialysis sector did not did not $1,80,000 per year gained while doing the oncotype DX. And that's published basically at the JCO and ASCO. Is this test real? And the other part is that where is the evidence that we need to heal? I am sure Hemant is going to have a watchword. So Hemant, before I end, I'm going to start with you. One line. Do you want Oncotype DX to be replaced in India by a more cost-effective test? Yes or no?
Unambiguous, unequivocal, yes.
Hemant?
Yeah, definitely. There's a big case for that.
Soma, what do you say? Do you think that we should?
Sir, absolutely. There are two issues. Number one,
Correct.
financial
Babu?
aspect and validation in Indian set of patients. For on both
Yes.
front, definitely yes, we need it.
Yeah, I definitely would say yes. But yes, just going back to that paper which you mentioned, that
Hello.
in spite of doing the test, they did not base their treatment on the result of the test. Any explanation for that in the paper?
Exactly. There's no explanation there at
Okay.
all for that thing.
Okay.
So now, before we
Okay.
move on, I'm going to ask Dr. Bakre has been sitting quietly. Dr. Manjari, I would like to tell you something with the data which is given and we have just showed you. Where do you place artificial intelligence and machine learning in prognostication of breast? And I also showed you a paper which has been published. Dr. Manjari? Dr. Manjari?
So I'm just unmuting one of the speakers so that Dr. Manji can speak.
Dr. Manjari?
Yeah, he's joining. She's joining just. I'm just sending.
Dr. Manjari?
Uh,
This is a terrible platform, I must say.
You have to kick somebody out to accommodate. And then,
Yeah,
I agree with you.
Really.
280 people are waiting to join,
I
but
know.
the full strength is 91. That's all it can accommodate. It says that maximum capacity reached 91 out of 218 waiting.
so attendees can join, but speaker we can only accommodate 6 speakers.
Yeah, no, but even speaker, it's even attendees, it says maximum strength has been reached.
I agree with you. Can Dr. Manjari
Yeah.
be unmuted,
Yeah,
please? Dr.
yeah.
Manjari?
Yeah, she's joining.
Manjari?
So I have
I
sent
know.
her invite many times, but she's
Yeah.
not joining. Invite as presenter.
Dr. Manjari?
Yeah, she'll be joining in a while. I have sent her an invite.
Should I start the screen share on?
So
Okay, that'll be fine. And I would just try to.
you can directly upload your
Yes,
slide.
please.
You can directly upload your
Yes.
presentation.
So I just press share my screen, right?
Anyway,
No,
I would
no.
really like to.
So you can directly upload your slides. Just click on
So
the
before I
slide.
finish, I'll just let me make a statement.
You can just click on the slides and then just upload your slides over here. Yeah. Add a new presentation. Click on the add a new presentation.
Yes. Presentation name.
Anything
Where
you
do I
can
select?
put. Anything you can put. Breast cancer, something.
Okay. Then
And then you can upload your slide.
okay. Okay, I clicked it. We are uploading. Actually, it takes some time, about 2 minutes.
Yeah.
I don't know the origin of this platform, but it's sad.
So usually you do all the webinars on Zoom.
Not just that, even Teams, then Google
Not
Meet,
just Zoom, several others.
Teams, Google Meet, Cisco
Yeah.
WebEx, they're all very good.
Yeah.
Okay.
All 4 platforms are.
This is the first time I'm using this, but it's bad.
So actually, we got this feedback from you. So next time we'll do it on Teams then.
Okay, what is it? It's not uploading my presentation.
It's not uploading. Why? Start presentation.
We have to throw somebody out of the room now.
Just no. So is this your presentation?
No, that's not mine. It is a virgin. No.
No, this is GS presentation.
Okay. So but what is appearing on the screen when you are uploading your presentation?
Maximum size 80 yeah. Just see that. Is it coming now? I think
Yeah,
it's
coming. It's coming. Yeah.
It told 80 MB. 80 MB is a very small presentation. It gave me a thread that it's too bulky. 80 MB, not even.
Yeah, it's coming.
So this is like in a place where you have no network.
But I have got one of the fastest network lightning
I know.
cable I have
No,
here.
exactly. That's what. But this
Whole
is
time
like,
I remember.
yeah. It's like we are in Antarctica.
This webinar jam is
Really bad. This is not Chinese, no?
No, sir, it's not Chinese. This is a
Whose is
US
it?
based. This is a US based company.
Must be Trump's. No, but this really is bad. Have you used it before?
Yeah, but for not such a big panel, for with 1 or 2 or maybe 3 speakers, it works very well. So we thought of because we
Oh.
already have this panel, so we thought let's do it for larger group also. But yeah, I also felt that it's not working that good.
This is bad. This is bad. Okay, good. You're thinking on the same lines. See, we're wasting so much time,
Yeah.
Where is so much
Sir,
slides?
I have uploaded it. It says that it needs 2 minutes to upload. So that I already clicked it. It says uploading.
Yeah.
It says.
Yes, it is
Yeah,
cloudy, so
I think
it takes time. It's
yeah,
very
it's from the
cloudy, so
clouds.
it
I
takes
know.
time.
So usually it doesn't
It's
take
from the
that
clouds.
much
I
of,
said no.
yeah. So usually it doesn't take that much of time. I don't know why it's happening today.
Maybe I've not paid the bill.
No, it's a
Madam, the proof.
it's a 1 year subscription base.
No, I'm just joking.
Yeah.
The point is,
Yes.
hello.
You had some more questions?
Yeah, I think until it uploads, take your questions.
I know.
Yeah, we can. The question is not clear.
Dr. Manjari is also not there?
Manjari has joined in. Manjari.
So I
Manjari.
have already sent Dr.
Dr.
Manjari.
Manjari.
So Dr. Manjari has not joined yet.
This one is just turning and turning.
So you can
It
try.
says please give me.
Yeah, you can share your slide also in that case.
Can you do one thing? I have emailed you my slides. Can you also try from your
Yeah,
side?
yeah. I'll just try.
Yeah, try that. Try that, yeah.
In your email, there is a set which is available for you.
Has come in now.
So no, Dr.
Arvind.
Manjari has.
Babu, you know what's the name of this?
Pardon?
Dr.
Babu, what is this
Manjari has
platform called? It is
Yes,
called
This is called
Webinar
webinar,
Jam.
webinar jam. JAM
I,
means
I have
jamming
joined.
It
everything.
is jammed.
It's called.
Yeah.
It's called.
It is jammed. True.
Yes.
True
Okay,
to
Manjari. By the time Soma
its
is getting
name, it is
ready,
jammed.
there was a question I asked for you. The question was, would you please, in short, tell us the role of AI and machine learning in prognostication in breast cancer?
Okay, sure. Yes, yeah. So,
Till Soma gets ready.
yes. I'll be quick and concise about it. So, essentially, I think artificial intelligence is really something that makes the processes and the programs, computer programs or prediction algorithms extremely robust because it has learned repeatedly, iteratively from variety of data, and it is a very common tool used not just in prognostication but even in radiology, in MRIs, in etc. In multiple applications, even in drug discovery. In breast cancer specifically, machine learning based algorithms, why are they more accurate is because it is strictly focused on maximizing diagnostic accuracy and hereby improves patient outcomes. Another reason that the machine learning based algorithms work well is because they have these transfer functions which are extremely flexible, and that allows them to model complex diseases, and cancer being one of them. It makes it feasible to predict, to model best, and hence it gives you a better prediction algorithm. With classical Cox proportional hazard models, which are typically used, the drawbacks are they're not ideally designed for optimizing accuracy, but they are instead suited for other purposes like hypothesis testing and parameter estimations, whereas ML based algorithms are more for complex modeling, etc. So that's essentially the main difference, and that's why we focused on in
Yeah,
Canada
I'm uploading. Yeah, I'm
SVM.
just uploading. Yeah.
SVM based method in Canas's breast because it is, and we really tried multiple methods of non SVM based methods, and we found that SVM based was most ideal because of all these transfer functions, kernels, which allows flexible modeling of the complex disease like breast, like cancer, and in specific breast cancer.
So, Manjari, let me ask you something.
Yeah.
You used a cutoff value, right?
Right.
What made you choose that cutoff value?
So we had we analyzed when we were so when we were looking at the data and setting the cutoff is really a most important task. So we looked at primarily what are the cutoffs set by other prognostic tests, and we saw that at that time Oncotype had cutoff at 12%, and I think Mama Print had also at about 10%. So we decided to do so those were some of the benchmarks. And also from our interactions with clinicians, we realized that the risk of recurrence could be to a patient uh, which is not who is not early stages and not treated is about 10%. And so these were the reasons why we wanted to bring our cutoff value under 10%, and we chose 9% as the cutoff.
So, in other words, you have used the clinician's stupidity to have a cutoff.
No, your practical and
To
very
make them
valuable
wise.
knowledge.
No, I'm just joking. Of
The
course, we need to
question
fall
is they
back on.
use the clinical stupid. No.
Yeah.
They actually did something. They actually validated the clinical stupidity with the intelligence of the MI.
Yeah. No, I was just joking, really.
Anyway,
Yeah.
no, that's okay. Manjari, let me ask you one more thing. You are basically using a protein markers, and there are 5 of them, right?
Correct.
I think Soma has almost reached. Yes, he has reached. So I think
So
Manjari,
would
some
you
other
say,
time if we have time after
Yeah.
this.
Yes,
So let's have.
absolutely. Yes.
Oh, Soma's
I,
again.
I have now become expert in logging into
So,
this, so I will not leave now.
so would you be able to see the slides now?
Yes, I can. We can
Yes.
see.
Yeah. So we
On a
can.
slideshow.
Yeah, I have just put it on the slideshow because the file was 17 MB, so I thought that is the problem why it's not uploading. So I'm just rolling the slide. You can just tell me next when you have to show the next slide.
Can't see anything. You can keep going.
Yeah.
You need to put it on slideshow. Try that.
slide.
So it is on slideshow right now.
No, it is not.
It's not moving.
No, it is not on full screen.
Okay. Just a minute. Yeah.
Yeah. Okay.
Next.
So Manjari, let's get back. Okay, it's fine.
Yes,
We have come
sure.
to this, so we can't do it anymore. Come on, move.
Yes, so
Soma,
we can
start.
see your slides. I think
Can't hear you,
you're
Soma.
muted, I think, Somshekhar.
Yeah, so most of the excellent points are already covered in the panel discussion, but specific to India and its data and what is their need for it, and cross comparing the Indian patient data with others is something which is there in the presentation which I'm going to show. The most important thing is we all know that the high risk patient is very clear to separate, but within the low risk we still have a lot of patients who could be high risk, and then the tests which are determining currently already GSB brought all the fallacies of various tests. Most of them are Western tests, not based on Indian validation, not on an Indian patient, and most of them are multi-gene panel. So the turnaround time is 2 to 3, 4 weeks. They're not IHC based panel, which is quite easy and which is easily replicable. And the clinical practice in India. Can I have the next slide?
Yeah.
Yeah, so this is something which is important for us to know. We have to cross absolute type of breast cancer. We know that one size does not fit all. Even though we know that we may have what appears to be luminal A and B, even there, the total absolute benefit from the patient is totally different. It varies as much as 2 to 3% in some to 15 to 20% in the other. Next slide. So this is, this is something which is very important. During my whole course, when I was in US or UK, and when I did my breast fellowship in Maggie Human Hospital, Pittsburgh, initially we thought cancer is such a bad disease, bombard everything with maximum tolerable disease, maximum surgery, maximum chemo, maximum RT, and then we come back. Then we understood we moved from an era of maximum tolerable treatment to minimum effective treatment, still not compromising the oncological outcome and yet maintaining the toxicity, quality of life and organ preservation. So more is not always better, less is always not inferior, and this is an era of de-escalation, but not blindly. It is very dangerous when all three people, the surgeon, medical onco, radiation, de-escalates in one given patient. Oh, then that's when it's a disaster. So, but how do we know in a given patient, which part to be de-escalated? We need a path. Next slide. So this is the clinical dilemma. The low risk, who can benefit with endocrine therapy alone, and those patients who are still HR positive but will not be sufficient to just give chemo, hormone therapy, but also needs chemo is something which is important. So prognostic tests and tools which aids clinician are, which is very important, which we need that. Next slide. So if you look back, the endocrine, even though we have 65% of HR positive, but we know that in India, premenopausal only 35%, and about 50 to 55% in postmenopausal. Indian data is different. Even in that subset, identifying the different group is very important. Next slide. So the clinical dilemma in this particular early breast cancer for us to know is not to undertreat a high risk, not to overtreat a low risk. So how to decide about it? Next slide. So we have various factors. Now we very well know that most of them don't take the genomics of this. In essentially, they are all TNM with ERP-RK67 combination, which are not sufficient for us to understand. And I'll show in the coming slide how these tools have performed with genomic assay. Next. So we know we had first generation and then we have second generation. So how does these fare with the Indian patients? We'll compare. Next. This is what is a landmark thing. You know, once the AJCC 8th edition told very clearly, you may have a what appears to be a stage 2 or 3, but the moment they fit into the low risk category and you apply a prognostic marker based on 58,053 patients with 5 to 7 year follow-up, they found that these patients needs to be reach staged, and once you apply the prognostic marker based on the genomic assay, they all behave like stage 1 low risk and they can be downstaged. So the AJCC modified their staging. 30% of the patient what thought to be low risk are upstaged, 20% of the patient more than are downstage. So now you can know over treatment and under treatment problem in the given set of patients. Next. So that's one of the reason majority of early breast cancer may not need chemo, which is actually what trials conclusion, but we will see how it applies to India. Next. Next slide. So this is something very important. We need to, this is a era of personalized medicine, patient centric care, where quality of life is something which is more important, where if the side effect of chemo can be avoided without compromising, we need to find a way to do it. Next. So redefining the staging is something which has been done hallmark. This is one of the most important change which happened in AJCC. After this, most of the insurance companies actually worldwide approved this genomic analysis. Next. So now you look back this particular landmark article, you can see all the authors which from India. The Indians people largely play from their pockets. So what is the consequence of over treatment in India? Because if you look back, 30% of the time we over treated, 20% we under treated as per the data of AJCC based on 50,000 patients. So this is a huge in India where people pay out of this. The cost of the entire test itself can actually be the cost of the treatment for us. Next. So we can't generalize what is validated outside. What is not, we all know in Indian breast cancer, it is 1 decade early and our type of breast cancer behave differently. So Asian patient, younger group validated in our group is something which is very important, and test which should not have a very long TAT is very important. Next. So the performance of prognostic test in non-coagulation. So if you look back carefully, this is a paper which clearly showed that all the important tests which was applied in 5 European center, Netherlands, 9 European, doesn't necessarily apply to the Asian population. In Japan and Korea, they saw and you can see that how, which is very unreliable when it applied to the Asian population. Now, if you look back the Indian population, then it is more diverse and it will be even more different. So Asian, Europe, there is a distinct way the PROS test varies. Next. So this is something. So suboptimal performances of all these tools in Asian patients. So there is enormous publication which are present, enormous evidences which came. To predict the accuracy of all these tests in Asian is not well defined. Next. So we have an expensive test, not validated in Asian patients predominantly, and most of it is primarily the Caucasian population. South Asian is not there, and then the turnaround time is very long, and most of them are not IHC based. Next. So you can see that these are some of the papers which were initially worked. So my colleague Dr. Poonam, Amit and Manipal, we did a lot of this particular validation from the CAN-assist breast, and then we published all this, and I'm going to share you what is the initial experience and then pan-India multicentric experience comparing this in Indian patient. Next. So this was one of the landmark paper which Manjari is there, which was published in Cancer Medicine, which actually validated the IHC based platform vis-a-vis the other platform which is based on genomic assay. Next. So this is something, this is my favorite, as a president of Indian Society of Breast, I always say we should find Indian solution for Indian problem, not straight away borrow all the evidences from outside which is validated in different paper and believe with a delusion of grandeur, yes, we have. So we should find Indian solution for our problem, Indian patients. Next. So this was something which I wrote it, Make in India, Indian solution for Indian problem was one of the author article from our society which we looked at. Next. So this has already been told by GSB. It's a sort of irony. You say don't use any other test, and IHC C4, which itself is not 100% validated, has been told. So we need to have some test which is validated in our Indian set of patients. Next. So these are how an Indian patient behave differently. Younger, aggressive biology, higher burden, and then we have totally different. We have a larger tumor size, symptomatic detection is more common, not screen detected, not smaller, but we have higher tumor, and then we have younger patients, 48 plus if it is 60 in the Western. Next. So you can see that, Manjari is there, their whole team worked on, basically, I had a long chat with her and went through the evolution of this particular test, serial analysis of so many biomarker, and which consistently proved significant were the 5 biomarker which were important for critical signaling pathways. Then the machine learning and statistical algorithm was done, then a morphometric analysis was done, then the cutoff score was arrived at, then the risk of low and high risk has been done. Now once you do all this work, the toughest thing is real world in patient, validating them, analyzing, following them for a long time, identifying the recurrence pattern, then also comparing and doing a concordance with the existing other proved techniques. Next. So what is beyond proliferation and hormonal indices that is important? Next. So you can see that these are the main paths which were taken. If you look back, the process of metastasis, one is the progression. So when you look at the mesenchymal transition, so CD44, N-cadherin, and then pan-cadherin, ABCC4 and 11. So you can see that you need a platform which predicts a proliferative index and also adhesion, then also chemo-resistant chemosensitivity. So these were the markers which has been seen. This slide has been visited by GSB already. So ultimately, out of various markers which were studied, a different level which is there. One which predicts the chemotherapy resistance, proliferative index, and then transmission of the disease and adhesions. So these were the markers which was actually used and validated. Next. So analytical validity, clinical validity of 1400, now it is much more, and then the recurrence pattern. So it went through these phase over last, when we worked out on this is 9, now it is about 11 years on which this validation, rigorous validation has been done, and these are the data. Next. So the clinical validation is as follows. So now if you look at following factors, so when the CAN assist breast, predicts it is a low risk, high risk. One good thing is there is no intermediate like what you have in RS score in Oncotype DX. So when this test says it is low risk and when this test says what is the high risk, you can see the Kaplan-Meier curve at 7 year clearly, very distinctly separates with a survival. What is the pattern? So low and true is real separation of the curves which you have even at 80 months follow-up. Next. So when you look back these cohort of patients which received endocrine alone, so the blue line suggests when the can assist says it is low risk and received only endocrine, you can see that even at 80 months the survival was 96%, and this is something which is very important to understand. So low risk prediction and high risk prediction. So high risk was 87%, which means very clearly it told that there is a sub cohort of patients which were treated with endocrine alone, and 98% accuracy was there for low risk. Next. Now, if you look back age, because remember, I told you in India, the average is 45, unlike 55 and 60 in Western. So when you see this test, can it perform less than 50 and more than 50? Because this is one of the most important. If you say more than 50, most of our breast cancer patient might be eliminated for us. Or if we have above 40, most of the time would not even need. They're almost really true low risk, which you can look at the parameters available. So you can see this particular risk even when they're young, less than 50 and more than 40, it validated well. Now, if you look back node negative and node positive, this particular analysis, when we are presenting our data in the Manchester breast unit, when me and Manjari went and we gave a keynote address there, we looked at node negative, node positive, because we know today for any one node positive or n plus, there is no clear test which is validated. But the proof of putting up a test is really to look at this particular area. If you look at node negative, node positive cohort, even then it clearly separated which are the patients which are hormone therapy treated alone or not. Next. So now if you look back, what is the high risk which are benefited by chemo? Remember, a test 3 parameter for any test: low and high able to separate with a cutoff score, low risk with hormone therapy alone, how they fared, high risk with intervention of chemo and hormone together, how they fared. So you can look back when it is low risk, practically the curves are overlapping, whether you gave chemo or not. So in those cohort of patients who received both chemo or hormone alone, practically the curves are overlapping when Canasi says it is low risk. On the contrary, when Canasi says high risk, you can very well see the survival difference of intervention of endocrine alone and benefit of adding chemo. So this clearly says which are those patients where chemo benefit is really there over and above the hormone. Next. So now how do you compare? If you look back Oncotype, it predicts low risk very well. The problem comes when it is high risk or intermediate. So you can see that there before the RS score goalpost was changed, even then you can look at it, it fares as poor as 60 and best at 91. So low risk Oncotype, very good. The moment you say high risk, that is when the Pandora box opens. Next. This is a slide which was not there, but on my special request, the whole team from Manjari and their team looked at it because I was a great fan of this. I know the Ki67 test in itself is not validated, but most of my patient in my center, I started seeing they were 10% and above. So I wanted to really see with our center, Ki67, is there a cutoff? This is like this. If you use Ki67 alone, based on HC4 and say high risk, they need chemo, but look back here. Ki67, if you look back as low and high, there is a lot of patients who are high Ki67, but still stratified as low risk. Ki67 low, but still stratified as a high risk. So the difference of survival when Ki67 was low was 3%, but the moment Ki67 was high, the difference when you apply Canassist was 13%. So don't go by Ki67 alone. You still need this Canassist test to segregate those low Ki67 which would still benefit with chemo, certain high Ki67 which still benefit with hormone therapy alone. Next. So, this is something which I wanted to say. The bottom line is ER, PR, HER2 Ki67, if you use and try to do as low and high, you are 19% wrong in low Ki67, 75% wrong when it is high Ki67. So you can't go with IHC4 with plus or minus Ki67. Still, you need to apply this particular area to do high risk. So these 3 slides are really my favorite. I looked at my subset of patients, and this is a good message for me. Next. So these are the various correlate, when you look at age, tumor, grade, and the therapy. We all know that the hazard ratio of 2 and above was something which is good. So this is an independent, irrespective of all this. Next. So the performance in Indian cohort of patients. Next. So in Indian cohort of patients, when you say endocrine therapy alone, you use NPV value of more than 95% is there in Indian cohort of patient in a large number of patients. Next. So in T1, T2, remember T2 is a very wide, varies from 2.1 and then you go down up to 5. So predominantly in Indian patient, you would get T2. So does it vary significantly in T1A, B, C and then T2? You can look back in T1 if you have 100% in endocrine, even when you have T2 cohort of group, it is still faring at 98% when it says low risk. So this is something which is, so we answered age if it is between 40 to 50, Indian cohort of patients, not just T1 if you have T2, and in Indian set of patient Ki67. Next. So if you have a can assist, how would it demonstrate chemo benefit? So when you say it is high risk and when it is low risk, you can see very well, when you have low risk, hardly any difference. The curve are practically same. But when can assist says it is high risk, then the chemo benefit and no chemo benefit in this is significantly separating. So that's the proof of pudding of any test. Next. So this is a independent factor in Indian Cox regression. Next. So when you compare now with what existed out, see, I remember I was in St. Gallen 2 years back, and I was shocked. Then there was a common industry symposium. Oncotype did first, Memaprint did next, then Prognostic third. The concordance between established, approved, not many people know that not all of them are USFDA approved. In itself, at best, is only 85%. I remember when Manjari presented this long before people, so, oh, you are 90% concordant only. Then she asked one question, do you know what is the concordance between a Memaprint oncotype and endoprict and this? 82 to 85%. So how does CAP performance with these others? Next. So this is one of the Taylor's trial. All the slides and blocks was taken and the group analyzed what is a concordance, because you already had a follow-up data and full analysis. So you can see that when you compare with the Taylor's data, if you didn't have this intermediate group with our Indian cohort, 17% of patients benefited more. You got better, more information than the Oncotype DX in that, which can clearly demarcate low and high risk when you compare Oncotype DX to can assist. So this is something very, very important, which is a big problem we have in oncotypes, that 17-20% of patients are gray area. Can assist was able to separate when you do a concordance study. Next. When you looked at Memaprint, any of the use of this is quite less, but still at that moment when this test was done, these were the two main things. You can look back this particular area. There was an 85% concordance between these two. When you look at it, this particular area, but when it is high risk, CAB actually predicted better. Next. So if you look back this all at the end of it, when you really need, CAB helped in Indian patients 64% to avoid chemo, because we always think Indian patients have high grade, grade 3, our sizes are big, we are not, but it still helps majority of our patients. Next. So this is my last two slides. These two slides I purposely put because when we went to Manchester in Australia, Western people have a fashion, no? Expensive is best, non-expensive. Then I just put this particular slide and told, India sent 104 satellite in one rocket at 1/10 the cost of what NASA sends. So this is something very important. Next slide. What Narendra Modi told, the charge of auto rickshaw from here to Mars is what we spent, and America spent a Mercedes-Benz charge. So we spent 1/10 of the cost and we still went in. So cheap is not necessarily inferior. Expensive is not best. Indian solution for Indian problem is important, knowing very well our patients, lot of them are between 45 to 55. They are not T1, they are towards T2. Key 67 grade 3 is different. Validation in our patient is something which is very important. Next slide. So this is my conclusion, and I would welcome any comments from Manjari, who has done the major research work. This is how me as a clinician would look into the practical application in my Indian set of patients. Thank you.
Thank you, Dr. Somashekar. This was absolutely fabulous.
Manjari, you need to have any comments because the hard journey you took it and we are reaping the benefit.
No. I mean, it's absolutely a pleasure to really hear the data from the clinician's perspective and how it's helping them. So all the effort that we have put in as a team is really worth every ounce. If when I hear the clinicians really enjoying, I mean, really benefiting from it, and patients as well. So no comments. Excellent presentation.
Babu, what is your comment on this? What's your experience with your patients?
Manjari, can I ask?
Yeah, go ahead. Yes.
Yeah,
Manjari,
sure.
Manjari, can I complete what you should say? You chose a protein-based test, not which is the fashion. What made you choose protein-based test? One. And why did you choose those? I know Soma went through it, but still I would say, why did you choose those markers?
Right.
Because those markers are not usually touted, although
Correct.
they're very well validated markers. In fact, they have huge data. Why did you choose them? Because this is just for everyone's knowledge that why is the background to the test. I keep saying, Oncotype DX does not know what the bloody genes are and what they mean. Right?
Correct.
So I'm trying to ask you, does CanAssess know this test that they did, what the test is?
Yes, absolutely. Yeah. So thanks for the question. And so first thing I want to tell is the goal of developing a test that is made in India on our patients is to really make sure it is useful for our patients. Then I mean, my background essentially is PhD in cell biology, so a lot of cell biology knowledge, which over the years on embryonic stem cells, on cancer stem cells, on cells that form tumors, various tumor lines, was what I had the background, and I wanted to really use this information to really understand why a tumor recurs and how it recurs. So when I went into the great depths of understanding this phenomenon well over various postdoctorate fellowships in the US and in Singapore, I realized that it's really the biology before anatomy is really important. The tumor biology tells you a lot, and there is more depth to it than tumor size and tumor grade. I'm not belittling importance of those, but you also, if there are two patients of the same size tumors, one may recur, one may not, and that the basic cause is the biology is different. So when I looked at the biology of breast cancer specifically, the hormone receptors dominate for sure, and HER2, but that we know by doing everyday IHC in the lab. So we wanted to really find out the genes, the proteins that are really critical, which really make a breast cancer tumor cell from the tumor in the breast to come out in the bloodstream and lodge somewhere else and make another tumor. So what are the important processes in this entire, not a very friendly and extremely hostile process? So those are the signaling pathways we looked at. And we actually looked at a long list of 40 biomarkers systematically, and with the help of statisticians, this strong machine learning based algorithm, we were able to narrow it down to these 5 signaling, really critical signaling events, which happen in the course of the spread of the disease from primary site to a metastasis anywhere in the body. And these 5 biomarkers were narrowed down in that process. But the whole goal was to really come up with extensive biological evidence for resistance. And also the other underlying theme of OncoStem is to come up with targeted drugs like Herceptin against the biomarkers which are well validated. And remember, this we are talking about HER2 negative patients, so they don't have Herceptin as a drug, and so we really hope to work with pharma companies on the biomarkers we have listed. Some of them are membrane associated, to come up with targeted drugs like Herceptin in future. So those were really the thought processes that went through our heads when we were narrowing it down, and really thinking through the biology was the most important aspect. I hope this answers the
Thanks,
question.
Manjari, for that explanation.
Yeah.
Yeah. Have you established any cell lines from these tumors that you have had specimens from?
No, unfortunately, we only work with formalin fixed paraffin embedded tissues.
Okay.
So, ma'am, it would be nice to see, but yeah, fresh tissues, would be nice.
Okay.
Manjari, I will ask a question, which most
Sure.
of the people ask. When you really started this test long before,
Yeah.
the tumor size and other parameters were not taken. If you see that the whole concept then was the biology is different than the stage, and if you look Oncotype DX didn't look at it, but probably the only other one is EndoPredict, which integrated the clinical parameters. So what
Correct.
made you
Yeah,
integrate
that's
this
right.
clinical parameter? And in your machine learning, like you say, at a scale of 100%, what percent is attributed to clinical high risk parameters and genomic? Is it like 50-50, 80-20, 60-70? What do you think?
Okay, yeah. So when we were developing the algorithms, the statistician in the US, we had told him very clearly that we would want a really biomarker-driven model. But then, as he was working on developing the model, when we always used to interact with the clinicians and take their opinions, and we realized that having clinical parameters is an important aspect. So we requested him to see the effect of adding clinical parameters into this model. So what he told us was so when we ranked all the biomarkers along with clinical parameters like tumor size, grade, node of this thing, the tumor size, grade, and node were really not the high ranking biomarkers, and that's why they were not picked in the model development. The first 15-20 were only the biomarkers, and the clinical parameters were on the lower side of the ranking, and the ranking is done with respect to importance in assessing the final decision. So then we told him that maybe you should overlay the model with these clinical parameters and assess whether now they are making sense more to the clinicians, more to the judgment, more to the decision, more to the outcome. And he felt that they improved the sensitivity of the test. So the short answer, Dr. Somashekar, is the majority of the weightage is still on the biomarkers, but I think the clinical parameters do help in making the model more sensitive. So it will be about 95 to 5% or about 90 to 100 would be the weightage of biomarkers to the clinical parameters. But it's very
Somshekar,
hard to
that
put a
was
value.
Yeah.
Yeah.
Somshekar, that was an excellent question that you asked. Manjari, if you really have the data, it'll be very nice to show that as well, because everybody thinks clinical is the most important. So if we show that it's not a very good correlation between the tumor characteristics as compared to the profiling that you're doing, it'll be a strong point, I think.
Sure. We
Babu,
can. Yes. Yeah.
Yeah,
Sure.
Manjari, can I make a comment here?
Yeah.
Yeah,
Manjari,
sure.
can I make a comment here? Babu, I have the data Manjari had sent me. I have been going through that data.
Okay.
I have been trying what is known as a weighted scheme for that.
Correct.
There is a rule, but then I'll tell you, the biologics actually, the protein markers actually outstrip basically even the node value.
No, that's excellent information. But if we can actually show that, it will
Hello.
be a very strong point.
Sure.
Yeah, I mean, that's being worked upon, Babu. That's being worked upon.
Okay, we can discuss that later. Yeah.
Yeah, sure.
Some excellent presentation.
Shall we call it a day?
Yeah. So thank you, everyone.
Great presentation.
Thank you for taking
really
our
enjoyed it.
time. Yeah.
I think we had a great panel meeting, and if there is any question, I'll take it. I saw one question asking what is the calculation that is used in the case of your recurrent score. So the concerned person called Mr. Johnny, if you want to hear it, I can tell you. It's a product basically looking at the HER2 group gene score, the ER gene score group, proliferative group, invasion group, the CD68, the GSTM, and the BAG1, of which the proliferation group and the ER group dominate actually in a big way. So that's the main drivers for this test. I hope that satisfies you. But then if you want the full formula, I can send it to you if you're really interested. Mr.
Uh,
Johnny, are you there?
Yeah.
GS, do we have any data for HER2 only segment of patients? HER2
Yes, Babu,
positive.
we have.
Okay.
We have, and that's
Okay.
the group people have been talking about, low HER2, and what do we do with
Yeah,
that?
yeah. Okay.
If you've been watching carefully, that's from Pike's group itself.
Correct.
The entire studies are from Pike's group, the low HER2 group.
Yeah.
Yes, they have data to that, and we will
No,
hear Fatima sometime in November talking
no,
about
I'm
this.
talking of the can assist group, which they validated. Did they have any? Did they have any HER2 positive patients, or they excluded them?
No, they haven't. Those HER2
Okay.
in the can assist thing is there in the data that came
Okay.
in the spreadsheets.
Okay.
Yeah,
Okay.
very few percentage are HER2 positive, Dr. Babu. Yeah,
Okay.
yeah, yeah.
Now, if we
But
have
we do have
some,
some of them because
okay.
traditionally they never in India in a
They
retrospective
behave
manner,
badly.
Yeah.
and they haven't received Herceptin.
Yeah.
So yeah,
Okay.
so it
Thanks.
didn't interfere in the treatment.
Right.
Shall we call it a day if
Yes.
Yeah.
the
So
hosts
should we?
allow and the hosts agree?
Yeah. So should we end the
Okay.
webinar?
Yeah,
Yeah.
thank
Thanks,
Yeah.
everybody.
So thank you,
Thank
everyone.
you all.
Yeah.
Yeah. Sorry, go ahead,
thank you.
Kanchan.
Yeah, thank you everyone from behalf of Dr. Lalpat Labs for taking out time for today's webinar. It's really interesting presentation and really interesting discussion. Hope the attendees are also get a lot of insight about the can assist and other prognostic tests of breast cancer. So I'm just ending the webinar now. Thank you so much. Good night.
Thank
Thank,
you. Good night.
thank
Good
you.
night.
Thank you all. Really appreciate Dr. Bhattacharya, Dr. Somashekar, Dr. Hemant Malhotra, Dr. Govind Babu, Dr. Harit. Really appreciate all the effort, and Dr. Rajiv. Sorry for what about. Yeah. So thanks for
Thanks,
joining us.
Manjari. Thank you.
Thank
Bye.
you, Manjri. Thank
Bye
you.
bye.
Bye.
Bye
Good
bye.
night.
Thanks, Kanchan. Yeah. Bye bye.
Bye.